Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Education Program Manager. It's my pleasure to serve as the host of the CGNE Seminar Series. Today, I'd like to introduce Megan Martin, Education Program Specialist, who's helping with this session today. We do appreciate your support with our center, Megan. This program is being provided by the Teresa Neese and Helen Diskovich Center of Geriatric Nursing Excellence at Penn State Ross and Carol Neese College of Nursing, in collaboration with the Office of Outreach and Professional Development, the Center for Nursing Research, and Age-Friendly Care Pennsylvania. Today's seminar, Balancing Workforce Shortages and Resident Preferences, Insights from Nursing Home Staff, will be presented by Dr. Nahida Akter, who recently successfully passed her dissertation defense. Congratulations, Nahida, and we are very proud of all of your accomplishments. Before we begin the presentation segment, there are some announcements and disclosures. Penn State Ross and Carol Neese College of Nursing is approved as a provider of nursing continuing professional development by Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. Participants with a valid RN license that attend the entire activity and complete the post-event evaluation within 1 week can earn one contact hour. Partial contact hours are not awarded. Certificates will be emailed to RN participants meeting all requirements within 1 month following the seminar. As a reminder, we do record these seminars. They are available on our YouTube channel if you'd like to review them again, or if someone has not had an opportunity to participate live. If you have a comment or a question during the session today, you can enter it into the chat feature, or you can select the raise hand feature and Megan will unmute you so you can speak aloud. And we certainly encourage all of you to participate in our discussion. The post-event evaluation link will pop up in your browser when the webinar concludes. It will also be emailed to you within 24 hours. This is required for RNs that are seeking contact hours, but we do ask that all participants complete the evaluation because it helps us with our data collection and it helps us plan future seminars. If you have any questions or concerns, you're always welcome to reach out to cgne@psu.edu. So with that, it is my great pleasure to introduce Light Nidora. He is a CGNE affiliate graduate student in his second year of his PhD program. Light is interested in studying the impact of social determinants of health on Black older adults living with dementia. We're also thankful for Light being a part of our college community as he brings a lot of light to our center's activities with his passion and his intelligence. Thank you, Light, for introducing our speaker today.
Thank you, Janice, for that wonderful introduction. I'll be introducing Dr. Nahida Akter, MSN RN, and is a PhD candidate in nursing at Penn State University, where her dissertation examines nursing workforce shortages and person-centered care in nursing home. Her research focuses on workforce challenges, staff perceptions, and strategies to improve resident care experiences in long-term care settings. Nahida has collaborated on multiple federally funded projects, published in leading gerontological and nursing journals, and presented her work at national and international conferences. She has extensive teaching experience in nursing research, administration, and evidence-based practices, both in the United States and internationally. Nahida has received numerous honors, including the J. Jeffrey and Anne Murray Fox Dissertation Award, the Doctoral Nursing Student Academic Excellence Award, and recognition as the Center of Generic Nursing Excellence Student Champion. Ladies and gentlemen, it is my privilege to present to you Nahida Acters.
Thank you so much, Light, and thank you so much, Janice, for having me. And that was a wonderful introduction. Thank you for doing that. So I'm just going to share my screen and let me share this. So, Janice, if you just confirm me like you are seeing the right screen, then I will start my presentation.
It's perfect, Nahida. Thank you.
Thank you so much. Good afternoon, everyone. As Light was introducing me, my name is Nahida. I just, defended my dissertation, and this study is all about my dissertation. So I will be sharing some wonderful findings that we found from our study. So our study was balancing workforce shortages and residents' preferences, insights from direct care nursing home staff. So without further ado, let's start. So this is the presentation outline, and at the end of the presentation, I hope that we will learn about all those things. So this study has three major constructs. One is direct care nursing staff, and the second one is workforce shortage, and the third one is person-centered care. So I'm going to introduce all those three major constructs gradually in the following slides. So let's start with the person-centered care. So Kitwood first 1997 emphasized that person should always be the primary focus of care. And that was the first time that people, kind of took it into account that we should create something that is person-centered care. That's how the definition is coming from. So if we want to define person-centered care, then we can say that person-centered care is a form of care in which the person can formulate their care plan and make decisions. And as you can see on the slide, that preference is one of the most important part of person-centered care as well. And preference meaning that it encompass the choices that nursing home residents make regarding their daily activities. So delivery of person-centered care is important. But why it is important, that's the discussion I will be focusing on this slide. Research shows that person-centered care focus on individual preferences. That's how it is important. And also research shows that person's functional status and social participation increase when we can provide the person-centered care. Also, resident satisfaction and capacity for self-care, it also increase if we can honor their preferences and implement person-centered care. And of course, the nurse-residence relationship that also get boost if we can implement person-centered care. But there are some, difficulties as well to implement person-centered care. For example, research shows that staff always face heavy workload. And they also says that there is not any consistent definition of person-centered care in all settings. That's why they don't know how to follow the person-centered care and how to follow the right dimensions of person-centered care. And of course, the resource limitation, that is another important barrier. That's why, still only 2% nursing home in US, they are implementing person-centered care. So this study actually took registered nurse, licensed practical nurse, and certified nursing assistant as their participant, because we know that registered nurse, they provide 1% of direct nursing care, and the licensed practical nurse, they provide 22%, and certified nursing assistant, they provide 64% total care. So that's how if we combine RN, LPN, and CNS together, we can say that most of the care, direct care, is provided by this direct care nursing staff in nursing home. So let's talk about workforce shortage. So there is a definition of workforce shortage from researchers' perspective, and there is also another definition from Center for Medicare and Medicaid Service, meaning that CMS. So first start with the researchers. So one of the researchers, they actually defined that workforce shortage occurs when the demand for employment surpasses the supply. Or, even if we have the qualified and willing worker, but we don't have the enough people to work on. So that's how the workforce shortage occurs. And the CMS, they actually defined that workforce shortage, we can say some facilities, they are shortage if it fails to meet the minimum staffing requirement. And we know that minimum staffing requirement is to have the minimum standard of 3.48 total nurse staffing hour per residence per day. So if any facility, they are not following that 3.4 total hour, we can say that they are in shortage. So in this slide, we will learn a little bit more about how nursing homes are really in shortage and what is the picture of nursing home workforce shortage. So statistics shows that around 60% of nursing homes have faced staffing shortage since January 2022. And also, it shows that almost 87% reported moderate to high shortage, with 73% concerned about potential closure. And also, statistics says that about 90%, 98% struggle to find out qualified applicants. So what happens if we have workforce shortage? So if we have workforce shortage, research says that it actually directs to poor patient care. Also, it lead to longer hours for the people who are working, and also it may increase error, and of course it may increase stress for both residents and both workers. And it also can reduce the ability to provide individualist care, meaning that person-centered care. And definitely we know the nurses burnout that can also happen from workforce shortage. So our study, why this study is important? Because there are a couple of other previous study, they have some gaps, and from that point our study is coming. First of all, one study was done in 2016 by Abbott and her team. So they actually focused on nurses' perception about preference-based person-centered care, but they did not solely focus on workforce shortage. And another study was done in 2022, and that was also an empirical study, but that just talked about perception of nursing's staff shortage in acute care setting, but there is nothing about preference piece, and especially in long-term care setting. And another study was done in 2022 that was a systematic literature review paper. So they did not include any perception of nurses, and they did not talk about any preferences. So this is how our study is important, to focus on all the missing parts. So purpose of our study was to understand direct care nursing staff's perception of workforce shortage and how it influenced preference-based person-centered care delivery in nursing home. So in this slide, you can see the theoretical framework. So we combined two theoretical framework. One was from 2000 that was developed by Dr. Christine Mueller, and another theory that was developed by same author in 2022. So we actually combined those two theoretical framework to support this study. And as you can see that the green boxes, those are our research question. So from looking at this slide, we can say that all of our research questions were well supported by the major construct of the framework. So let's talk about the methodology and participant sampling technique and data collection and data analysis we used for this study. This study was a qualitative descriptive study. And as I was saying that this study included RN, LPN, and CNA who had, the age at least 18 years and at least 1 year of working experience. And those people speak and write English. And of course, there are another important inclusion criteria. that was self-reported perception of workforce shortage, meaning that, sometimes they are okay on paper. I mean, they are okay in terms of they don't have any shortage on paper, but still people can perceive shortage. So inclusion criteria was that people who really perceive shortage, we just included those people in our study. And of course, we took their voluntary consent before our interview, and anyone that does not, meet the inclusion criteria, we excluded them from our study. So sampling technique. So we actually did purposive and snowball sampling for this study. And we, of course, ensured the data saturation. And we classified our total participant, meaning that RN, LPN, and CNS into two groups. One is licensed, and RN, NPN were included in licensed group, and CNS, they were under the unlicensed group. First, we started our data collection in Pennsylvania. Then we expanded the data collection to other US states. So total 5 states actually we collected data from. And we used our social media platform as well. For example, Facebook, Instagram, LinkedIn, Twitter to circulate our flyers. And we also use our network. For example, we use CGNE's network, and we used our professors and our personal network to reach out to our participants. And participants who actually said that they are okay to, involve, so we actually send them consent form via email so that they can see the total research guideline there. And of course, the IRB was obtained from Penn State University. So let's talk about data collection procedure. So initially we were thinking that data collection we can do both in person and Zoom. We kept both options open, but ultimately we saw that Zoom was more convenient because the data was collected from different US states. So that's how we ended up doing Zoom interview only for this study. And we used semi-structured interview guide. And of course, at the beginning of the interview, we took the verbal consent from our participant, and everything was recorded via Zoom. Total time for the interview was 46 to 60 minutes, and everything was stored, in secured, password protected Pennsylvania State University's cloud. So for the data analysis, we actually used inductive coding thematic analysis, and we followed Brown and Clark's 6-step method. So the first step was familiarize with the data, and the second stage was generating initial codes, and the third stage was searching for themes, and the fourth was reviewing theme, and then gradually defining and naming theme, and the last one was writing the report. So that's how total 6 steps we followed. For study rigor, we kind of made sure that credibility is ensured. For example, for doing that, we did member checking, and member checking mean we took a small amount of people who did the interview for our study to share our study findings with them and to kind of learn a little bit more if they have any feedback on that. So that's how we ensured member checking for this study. And details of our study participants are shared so that transferability is maintained 100%. And as I was saying that this analysis was coded by 2 coders blindly, and whatever conflict we had the weekly meeting to resolve all the conflict with our experts. And also we took some reflective note when we were doing the interview. So at the end of the interview, we actually compared that with our transcript so that we can ensure the conformability as well. And all code and theme, all code books were reviewed by experts from our committee. So let's talk about the most important part, which is result of this study. So first of all, we saw that most of the people we took interview from, they were female, and the percentage was 89.5%, which is not surprising, especially for nursing profession. And we also saw that the largest group of people were 18 to 29 years, and majority are white. And we actually intentionally tried to recruit equal number of people for both group, I mean licensed group and unlicensed group. we can remember that total 10 people were under unlicensed group and total 10 people were licensed group and the total 9 people were unlicensed group. So total 19 people participated in this study. And most of them had 3 to 5 years experience, and some of them also have more than 21 years experience. We saw that most of our participants, they had bachelor degree and they have some professional certification as well. But when it comes to professional organizations, we asked them, then do you have any professional organizations that you are right now connected? So most of them said they are not associated with professional organizations. And the interesting thing is, most of our participants, they said they do not have person-centered care training and they do not have zero specific training, even if they are taking care of zero people. So our study, we did find one overarching theme, and we also found 4 sub-themes and total 7 categories. We'll talk about all the findings later in the slide, but for just by looking at this summary slide, you can say that all of our research question, RQ1 means research question 1, RQ2 is research question 2, and research question 3 and research question 4. We had 4 research questions. All the questions are kind of well supported by the categories and the sub-themes and the overarching theme. So our overarching theme was perceived workforce shortage is a driving factor in person-centered nursing care implementation. Our participant mentioned experiencing workforce shortage a total of 146 times across the 19 transcript. So that's how we found that they really perceive workforce shortage. So as for the example, as you can see, their direct quote. For example, one of our RN, she was mentioning that I am the only staff on the hallway and I have to leave the unit with the residents in order to honor their preferences, and then there will be no one on the unit. So I want to honor what she wants, but then I cannot leave the unit. And another CNA, she was also mentioning that our ratio is usually 1 LPN to 22 to 25 people, and which she thinks too much. And I also agree with her that taking care of 22 to 25 people is too much. So our first sub-theme, that was the challenges of person-centered care implementation. So our participants said that residents' complex care condition that also drive workforce shortage. For example, one of the LPN, she was mentioning that, some people they have cognitive disorder and some people have hearing disorder. Try your best, but because of those kind of characteristics, you just couldn't honor their preferences. That's why they identified residents' complex care condition as one of the barrier to implement person-centered care. And also our participants said that staff perception regarding underlying reason for shortage, lack of time, staff job dissatisfaction, all those things are also working as a challenge to implement person-centered care. For example, one of our CNA, she was mentioning that sometimes their preferences may take longer and it may take time, more time than we have allotted for caring for them. So that's why I cannot honor that because I am in the middle of caring for somebody else. So let's talk about our second sub-theme. We also tried to find out what are the facilitators that is helping to implement person-centered care. So we saw that good leadership and policy strategy that can be helpful to support person-centered care and improve nurse retention. For example, one of our CNA mentioning that, better pay, it should be and it could be a little better. I mean, if our leadership and policy support and advocate for better payment, it can be a good facilitator to implement person-centered care. That's what our participant is emphasizing on. And another important facilitator we found is relational care support between residents and staff. And our study shows that relational care support can help to improve residents' well-being, and it also can help to improve job satisfaction among the staff, and it also can help to improve family reassurance. So one of our CNA, she was mentioning that I'm very friendly with the residents and they love me very much. So when they see my face, they understand. So from this direct quote, we can see that if there is a good relation between the resident and staff, it can be helpful to implement person-centered care. So let's talk about our third sub-theme. And our third sub-theme was nursing resource that are being used to honor residents' care preferences. So we saw from our participants, they said that there are a couple of tools they use to know residents' need, and they know to know the residents' need and to get to know the residents a little bit better. For example, they use questionnaire, they use direct observation, and they use EMR record, the data set as well to know residents' important care preferences. And also some of our participants, they mentioned that familiarity with the resident that also help to know residents a little bit more. For example, one of the CNA, they mentioning that now with the help of this tool, it will evaluate their needs and track some of the changes, meaning that our participant is focusing on these are the tools and these are the method they use normally to know the residents' need a little bit more. And also nursing resource, our participants said that ongoing training, ongoing learning, hands-on experience, and mentoring from experienced nurse, all those can be act as a nursing resource to honor residents' care preferences better. For example, one of our CNA, she was mentioning that there should be trained on workforce planning and on recruitment too and the retention strategy. And there should be always, some training on effective communication, conflict resolution, and negotiation skills that would help us manage staffing conflict and improve teamwork. That means she clearly mentioned like this kind of training can be helpful to implement person-centered care better. So let's talk about our fourth and final sub-theme of this study. And this is the biggest sub-theme we found. And that sub-theme, we saw that the impact of workforce shortage on nursing practice. So under these findings, we actually kind of like tried to select what are the impact workforce shortage can have on nursing practice. So the first impact we saw that workforce shortage can lead to change in care quality and safety. And this is not surprising because there are already some research out there. They are also supporting the same findings. And also we saw from our study that because of workforce shortage, that can become all the work, all the care people are providing, staff are providing to residents, it is becoming more task oriented and they are providing only the bare minimum. So one of our RN, she was mentioning that again, like we get the job done, but it is the minimum. So that's how they are emphasizing on the workforce shortage can make your task just the bare minimum. Also, our study shows that because of workforce shortage, there is a chance to increase error and definitely it can eventually result in staff firing as well. So we also saw that because of workforce shortage, there is a challenge between communication among the staff. For example, one of our CNA, she was mentioning that I noticed that we have a very poor communication among staff and residents, and it leads to misunderstanding and misalignment with resident preferences. So from our study, we're seeing that because of workforce shortage, the effective communication that can be hampered and gradually it can lead to misunderstanding and misalignment with residents' need and preferences. Also, we saw that because of workforce shortage, it may impact staff's clinical decision making. For example, there are, participants said that one of the CNA, she mentioned that it's kind of leaves me where I have to shower her, but I know that she would prefer is a bath. Meaning that that resident wanted to have the bath, but because of the workforce shortage, staff had to do the shower. And another important workforce shortage impact is it can cause emotional exertion and burnout, especially for the staff. So one of our LPN, she was mentioning that, well, the thing is when you work short, the nurses' aides are overwhelmed. they are in tears and I am in tears because they are upset. I cannot fix their problem. My RN cannot fix my problem, and there is nobody to fix the problem. So we can clearly understand from this direct quotation that how much shortage we have and how emotionally burnout our nursing staff are. Also, one of our LPN, she was mentioning that burnout is not a joke. It's not a joke. So that was our findings from this study. And we kind of try to differentiate between the perception of two groups, meaning that licensed staff and unlicensed staff. So we know that licensed staff, meaning that RN and LPN, they mostly work for the supervisory role. So they said they are mostly focusing on structural and system level issue, and they are more focusing on mentorship and formal care planning tool. On the other hand, unlicensed nurse, they are providing, 64% of the direct care. So that's how they are more focused on emotional exertion, hopelessness, and day-to-day struggle. And they are more advocating for pay and all those things, which is, making more sense because they are taking care of the most of the daily direct care. But both of the group, they actually agreed on one point, that shortage can hinder safe, high quality care, and also it can hamper the individualized interactions. So there are some important discussion points from this study. For example, these are the findings. This is the findings we found from our study, and also it is supported by the current, the study. For example, we found that complex residence care need, that is one of the barrier, and expectation from residence family, that is another barrier. So there are some other research already out there. They are also saying the same thing we found from our study. And our study, we saw that supportive leadership and a strong relationship with resident, that can help to facilitate person-centered care more. That is also supported by the existed, literature already. And we saw that tools like questionnaire, EMR, and other thing that is being used as a nursing resource, and our other study saying the same thing. And also we saw, as for effect of workforce shortage, we saw that it can compromise resident safety, communication, care quality, and clinical decision making. It also can increase workforce workload and all those things. So there are some other study is also saying the same findings we found from this study. So what are the other things that we are adding new from this study? For example, our study is uniquely saying that staff perception of shortage matter. For example, as I was saying earlier, that maybe they are okay on paper that they are not on shortage, but still, people, staff, direct care staff, they may feel that they have shortage. So that study, this is how our study is solely focusing on staff perception of shortage rather than the paper shortage. And also our study is uniquely presenting that there is a lack of person-centered care specific and workforce management training. As I was presenting earlier, that our participants are focusing on, and they are emphasizing to have more person-centered care specific training and workforce management related training as well. And also our study shows that policy play an important role, and it can act as both barrier and facilitator to implement person-centered care. And as for, our study, we combined both framework from Mueller, and from this both framework, we are actually presenting a new integrative framework, and that will need future validation. So let's talk about that theoretical framework. So from this study findings, with the existing framework, we are adding some few more construct. For example, as you can see the orange color. So from our study, we saw that family is important as much as resident and staff. So because family is also influencing nursing practice model. So this is the new construct that we are adding to existed, framework. And we also saw that existed framework, they talk about staff characteristics, sorry, they talk about residence characteristics, but they didn't talk a lot about staff characteristic. But from our study, we are seeing that staff characteristic is also important, and that can equally impact nursing practice model as well. We also found that structural, along with the structural support, policy support is also important. That's how in orange color, you can see that we added this policy component to the existed theoretical framework as well. So do we have any practice implication from this study? The answer is yes. For example, enough staff, our participants said that we need enough staff on all shift. Specifically, we need more staff in evening and night shift. And also, we need to support our staff emotionally. We need to promote teamwork, and we need to foster good leadership practice as well. And also, there is a need to provide practical and need-based training among the staff. Also, our study is saying that including residents' preferences in care planning and quality checks that should be ensured to provide person-centered care. Also, our study says that addressing shortage, system-wide with better payment, better condition and training, that can be helpful. Also, we have some policy implication as well. For example, we have some national level policy implication. For example, we are showing from our study findings that there is a need to understand staff perception of shortage, and we also should recognize staff well-being as a quality measure. And we also should include practical training as part of their daily routine care so that they have better understanding about person-centered care. We do have some state level implication. For example, regular staffing check and clear public reporting can be helpful. And our study is also showing that there is a need to fund more person-centered care continuing education, as I was saying earlier, that there is a need to have this training program as well. And we should definitely support our staff retention with their incentive, better incentive. And this study is also advocating for creating the workforce task force with the frontline staff's perception so that they feel that their voice is heard. And also we do have some nursing home level implication. For example, our study is showing that assessing and documenting residents' preferences is super important. Also, we need more teamwork and we need open communication between the staff member. And we also need to train leaders as well to support better management. So we have some research implication as well. For example, in this study, we did not include any residents and family perspective. We just included our staff perspective. So for the future study, we advocate that they can include residents and family perspective as well to have the better understanding and the complete understanding from different group of people. And also, we did not compare that much between the role, facility type, and regions. So we advocate that future study can compare their role and the facility type, and they can also compare the region as well to have the better understanding. Also, another thing is as I was saying, that there is a need to test intervention that can help staff honoring residents' preferences. For example, maybe there can be some technical support or, there can be some technological support that we can use to reduce some of the burden from our direct care staff. So future study can focus on that as well. And we believe that using the mixed method study, that can be helpful to, know a little bit more, the quantitatively and qualitatively. So this study, our current study, was just focusing on qualitatively. So we advocate for future study, they may do the mixed method study to have the quantitative perception as well. And from our study, we saw that there is no concept analysis for workforce shortage, especially the perceived workforce shortage. So having a workforce shortage concept analysis can be helpful as well. We do have some limitation as well. So first of all, we had only 19 participants and 6 nursing homes that was included in this current study. So we advocate future study, they may include more people from different nursing homes from different states as well. And also, as I was saying, that we did not take a wide range of people, so that's why result may not be widely applicable. And we also said that we just included staff perspective. So definitely having residents and their family perspective can be helpful as well. We have some takeaway home message for all of you. So the first one is perception of shortage can be useful to address actual workforce shortage. As I was saying couple of times, that perception of shortage is helpful. And it is equally helpful to know the actual paperwork shortage as well. So this is our key home message, that perception of shortage can be useful. And another second takeaway message we have from this study, that was that supporting staff's well-being, addressing complex residents' need, and fostering relationship, those are the most important vital thing as numbers on paper. Those are the real important thing. So that was it about our study. And this is the scan code. If you need the references, so you can just scan it and can have the full reference list here. And here is my contact information. So you can email me. And if you have any question, I would love to hear from you guys. Thank you so much.
Well, thank you so much, Dr. Akter, for that amazing presentation. I had the privilege of being at your dissertation defense, but I think I've learned that much more from the enhanced presentation you provided today. So thank you so much for sharing that wealth of information and that critical background that you shared at the beginning of why workplace shortages are so important as they relate to their staff's ability to implement person-centered care, and what some of the consequences of not having adequate staffing in terms of quality of care and quality of life for residents in nursing homes. So thank you for sharing that. The study is very fascinating, and I look forward to more studies in the future regarding this. Lots of positive comments in the chat. Congratulations for an awesome presentation. Ariel O'Brien does say, a small sample or not, I would be shocked if the data would be different across other locations, at least in the United States. Do you want to comment on that at all? What do you think about that? Oh, you're on mute right now.
Yeah, I'm sorry. Can you please read that again, Jana?
Sure. So it's a comment, but I'd like to see what you think about this. It's a small sample or not. I would be shocked if the data would be different across other locations, at least in the US. So I'm taking that that they think it would be pretty consistent across the United States.
Yeah, I totally agree. And thank you so much for that comment. So this is our future plan to do this study and expand a little bit more. I know shortage is global thing. It's not just, United States. It's a little bit global thing. So we would love to expand and see a little bit more. Is it the same situation happening in other states of US and maybe, internationally?
Have you considered, you mentioned the 3.48 minimum staffing levels. Have you considered maybe using that as a metric, when you compare feedback from staff at one care community versus another, and what their average staffing levels may be, and if there are any different perceptions as compared to their staffing levels. Does that make sense?
Yeah, that's a great point, Janice, because we didn't do that in this study, but we are highly recommending for the future study to do that because we believe that comparison would help to make more sense, especially among the, it can be the licensed group, what they are saying, and the unlicensed group, and the facility type, like we have different types of facilities. So that comparison can make whole lot sense.
Yes, yeah, absolutely. And I think, you shared that, that what the staffing levels are on paper don't always match their perceptions of their staffing levels and their ability to provide high quality of care. And you gave a lot of good reasons for that. So thank you for explaining that well. Lots of positive feedback about your presentation. Dr. Diane Barish says, excellent, Nahida. What would you say is the most important finding your study produced as far as policy implications?
That's a great question, actually. So we would say that, especially for policy implication, that there are, the minimum staffing rule, we all know that facilities are trying their best to follow the minimum staffing rule. But when it comes to reality, when we talk to our real people who are taking care of our residents, they are saying that having that rule is important, and equally it is important to understand their real feelings, because sometimes they try their best to fulfill that requirement, but at the same time they feel exhausted. So kind of like the balance, we don't know the real solution, what can be the best solution to balance out those two situations, but we know that there should be a middle ground, so that people also can feel little bit relief that we have the minimum staffing rule, at the same time we're doing our best to support our staff. I guess
Yeah.
that was the key findings and key implication from this study.
Yeah, and that makes me wonder, in these interviews that you had, did any of the staff members give you any specific strategies that would be helpful for them to feel better about the work they're doing, the care they're providing, and feel less stress and less burnout? You mentioned wellness and incentives, and I think you talked about pay. But did you get any, other sense about what leadership could do to promote wellness and any specific incentives that they had ideas about?
That's a great point as well, Zenas. So we do have separate whole study. So last year we did that pilot study and we interviewed leadership people for that study. So we asked that question to them as well. Hey, is there any strategy from leadership perspective you are doing for staff? So there are some wonderful findings we found from that study, and we're going to present that at GSA, this year's GSA, that findings, but I'm just saying a couple of things our leadership people are doing. For example, one of our leaders, she was mentioning that, hey, although we are leader, but we jump on the real direct care when they need us. So we feel like we are the total team. We are not just leader. We are also a care provider. So we are trying our best to ensure that we are also taking care of people with them. And when they need us, we are just right there on the floor. So that is one of the, great strategy they're doing, and I appreciate that they're doing that. And another thing is like they are having some wonderful like support system. Some of the facility, I'm not saying that all of them, but some of the facility, they are having some wellness training, they're having some counseling program and all those to support the mental health of staff. So they started doing that, and we advocate that all of our facility, they also can do the same for our staff.
That's awesome. And I love the fact that our college has a strong focus on wellness too,
Yeah.
to teach our undergraduate, our graduate students, faculty, staff, such an important part of life and work for all of us. Solomon says, I'm curious to know what plans you have moving forward, your new constructs about Muller's theory in the future.
Yeah, that's a great question. So our plan in the future that we will do the validity test for our proposed adapted framework, because still that part is not we did. So, but in the future, we're planning to do the validity test for our framework so that we can kind of like propose this complete adapted version of the current existing framework. So that's the plan.
It's great. Again, lots of congratulations on this dissertation project and wonderful presentation. Ariel is saying international comparison could also be interesting. What are your thoughts on that?
Definitely. So my background is international. So and we did some wonderful work that was back in Bangladesh. So most of our work, if you go to our LinkedIn, we can see that most of the Bangladeshi research we find that like same findings, and it is huge compared to US. The shortage is huge in Bangladesh because we only have 35,000 registered nurses to take care of 20 crore people. 20 crore, I don't know like how many millions, I cannot convert that, but 20 crore people we do live in Bangladesh. We have only 35,000 registered nurses. So you can just assume the, severity of shortage. So all of our previous work also saying that people are just leaving nursing because they cannot take anymore. And we're seeing the kind of same situation in US as well. So I appreciate that you made that comment. I guess in future we can kind of like compare the international perspective with our US perspective as well.
That's very interesting. It would be fascinating. Just a reminder to participants that certainly you can continue to put your comments or questions in the chat, but if you'd like to unmute and share your question aloud or your comments aloud, Megan's on standby to do so. So Dr. Donna Fick, who is the CGNE director, as you know, comments, excellent presentation. This will give you a decade of practice and research implications. So congratulations on that. And I think you did a great job explaining, those potential implications. If you were to think about education, what could we do, with our undergraduate nursing students, for example, or at the facility level, related to education around this topic?
Yeah, sure. So, from my understanding, I'm not too much familiar with US curriculum, unfortunately, yet, but I would love to know that if there is a whole dedicated, curriculum regarding the person-centered care implication. So, if we do have that, it will be super helpful for the people to understand what is person-centered care and how to take care of, residents' preferences, all those things. So, that can be one of the things. And another addition from the education perspective is like to have some sort of like, education regarding how to manage the situation, emergency situation, and those kind of shortage, if there is shortage and all those things. So how to do that, how to kind of like work under shortage situation or under any emergency situation, that can be helpful to have that. But maybe there is already, but I don't know. But those two things I was thinking.
No, I love that. I think that sometimes you described it well in that one scenario where the nursing assistant knew that the resident's preference was to have a bath, but they didn't feel they had the time or capacity to do that. And so they gave them a shower instead. I think even, creating the type of culture where people can bring that forward, that here's a situation, here's an issue, and we need to work together as a team to solve this problem. When I was a director of nursing, I had a resident, I gave them my phone number, and she called me at my office and said, I need to speak with you. So I went to her room, and she was complaining about the nursing assistant showing her an attitude. So I went out and interviewed the nursing assistant as well as a few other staff members and learned that in the morning when they were busy getting people ready for breakfast, doing AM care, this particular resident wanted the nursing assistant to stay in the room for about 45 minutes doing, different things to kind of prepare her bed and different things. And so we worked with the housekeeping staff, and the housekeeping staff spent some of their time in the room helping with the bed, so to free up the nursing assistant to do something else. And then later in the day, the nursing assistant helped to put garbage bags in the garbage can. So just an example of how, using some problem solving, good communication, doing some teamwork, to address those unique situations, I think can be super helpful. So
We do have
Clarice,
hand
Oh.
up online as
Oh,
well.
good. Yeah, that's great, Megan. So Megan's going to unmute you so you can share your comment or question aloud. I think they're still muted.
Yeah. I've asked them to unmute,
Okay.
but we do have a question in the Q&A if you wanted to hop to that one. And then when we hear back from this other person online, we can hop back to them.
Okay. Okay. Are you talking about Clarice's, the nurse that mentioned 22 patients were too much? Made me think how HPRD, and I'm not sure what that acronym means, so someone might need to help me with that, is talked about in studies and is relative to census. Average nurse to patient ratios are not talked about. It evokes a different response. Clarice, would you like to unmute and share more about that? If you'd like to unmute Liza or others, you can. Megan will do that for you. You just have to signal by raising your hand.
Yes.
And I apologize. I'm not sure how to pronounce the name that's on the screen. The last name is Oliver. If you wanted to speak aloud, you have your hand raised. You can unmute. Megan has allowed that to happen.
Liza, would you like to be unmuted to say anything?
Hours per resident per day. Oh yeah, thank you
Okay.
for reminding me. I knew that once upon a time. Thank you, Liza. And Diane saying that too. She says she's good.
And we had
Okay.
one person in the Q&A just asking if they could see the last slide again about perceptions of staffing shortages.
Yeah, sure. Let me share again. This one, last one.
I think so.
Okay.
And it looks like Donald Dissinger, if you have anything to add or you'd like to see differently, a different slide, just let us know.
Okay, we're unfortunately almost out of time. So I want to take this moment and extend a sincere thank you to Dr. Akter for this fabulous seminar. Thank you so much for sharing your dissertation project, for all this amazing work and the potential for future studies as well in this important area of care and quality of life for residents living in nursing homes, as well as staff. So thank you for sharing all that tremendous work. Just a reminder to participants that when the webinar ends, the evaluation tool will pop up in your browser. If you have time to complete it then, please do so. And if you don't, it will be emailed to you within 24 hours. We do appreciate, your completion of the evaluation because that gives us a lot of helpful information. So thank you again to Megan for helping out today and to Nahida for a fabulous presentation. Everyone have a great day.